Welcome to the 6th annual Meredith Drench Lectureship. You can read in your brochure that Dr. Drench established this lectureship to encourage Sargent College to continue her belief in the compassionate rehabilitation of the whole person. And sadly, Dr. Drench died just this year, less than a year ago. But indeed, Sargent does continue her belief. And in fact, I would say that this is core to the mission of the professions taught at Sargent College. And I hope I can say also it's core to the mission of the nursing profession. So our speaker today, Dr. Daley, is a very appropriate speaker and interesting story. There currently is no nursing school at Boston University, but there used to be. And Boston University produced over 9,000 nurses. I was told some of the alums might be here today, and I'd love to meet them. But it is my hope that the nursing alums of BU can consider Sargent College as their home base at BU and feel welcome to join all of our programs. Dr. Daley's CV is a very interesting read. Just a few key points. She's a real Boston person. Started at La Brea School of Nursing across town, where she got her RN. Went on to Curry College, where she got a Bachelor of Science in Nursing, and then came to Boston University. But not the nursing school, the School of Public Health, where she picked up a Master's of Public Health in Behavioral Science. Then she made the short trip across town to Boston College, where the nursing school, where she got a Master's CNS in Community Health. And then more recently, she received her PhD from Boston College. Her CV contains many publications, many honors and awards, too numerous to mention, but notably she has been named one of the top 100 most influential leaders in healthcare. And even more so, one of the top 25 women in healthcare. So we're very fortunate to have her here today. In addition, but not really on her CV, she has a fascinating personal story that she's going to tell us and is probably best summarized in her title, My Personal Journey from the Bedside to the Halls of Congress. Dr. Daley.
Thank you, Dr. Morgan. And I always tell people that when the bean pot rolls around, I'm covered at least for 50% of the winners by having gone to BU and BC. So always, I'm very proud of the fact that I had the opportunity to go to Boston University for my public health degree. I'm also mindful of the fact that, as Dean Morgan said, this is the first address since Dr. Drench passed away. And I actually picked up both of those publications just to skim through them because I didn't know her personally. But the connection and the concept of health not being bound by care of the physical body is an important concept. It is one that we embrace in nursing in terms of caring for the whole person. And that includes the psychosocial and I'd say even the economic aspects of the context of people's health. Very important social determinants of health, very important considerations as we care for people in this country. But clearly we're challenged in this healthcare system based on resources and other barriers to be successful often in making sure that we extend the kind of holistic lens in our care of patients. So I'm thrilled to be here for this, in Dr. Drench's name, this important annual lecture. I hope I do it in her honor and do it well. Before I talk about my own story, though, I just wanted to bring your attention to two quick stories, both out of the Boston area, and many of you may have remembered that in, I want to say in July of 1995, Kenneth Schwartz was a healthcare attorney who actually was being cared for, was diagnosed at the age of 40 with lung cancer, and only lived 10 months beyond his diagnosis, had a very aggressive form of lung cancer. But prior to his death, he not only established this center, which is scaled out now beyond Massachusetts, beyond Mass General, to I think over 30 states, has some type of compassionate care rounds, and really established this center in order to bring attention to the fact that compassion within our care, provision of care, is a critical component of what we do to heal people. One of the things that he also did just a short time before he died, and I remember reading it the day it came out in the Boston Globe magazine, he actually wrote an article and chronicled his experience as a patient from diagnosis until the point when the article was written. And he described his experience within the healthcare system. And I just want to read a couple things that he wrote in that. In fact, you can still Google this and read his own account of his experience. And I think it's very poignant in terms of where he placed the value, where he really received the most comfort is he went through some pretty horrendous experiences in terms of his disease progression. He talked about his 10-month experience as, and this is his quote, "It was an ordeal punctuated by moments of exquisite compassion. I have been the recipient of an extraordinary array of human and humane responses to my plight. These acts of kindness, the simple touch from my caregivers made the unbearable bearable." That really was the bent of his article in the Boston Globe magazine, was the fact that he went through he was on the receiving end of a lot of very expert care that wasn't able to interrupt or suspend even the progression of his lung cancer. But what made him able to move through it and to come out the other end with some appreciation for life in spite of his fight with his disease was the compassion that many extended to him. And he describes moments in that care. He ended his story with these words: "If I've learned anything, it's that we never know who, when, or whom a serious illness, or when, how, or whom a serious illness will strike. If and when it does, each of us wants not simply to get the best possible care for our body, but for our whole being." And that was really the kind of a consistent theme throughout what he wrote. The other article I read in February, and some of you may have seen it, Dr. Arnold Relman was a very well-known academician. He was an educator out of Harvard. He actually taught here at BU at the School of Medicine for a number of years. Was the editor of the New England Journal of Medicine, and Dr. Marcia Angel, his wife, is the current editor of the New England Journal, but he's in his 90s, and I think it was about 10 months before he wrote this article. He lived in Cambridge, had just celebrated his 90th birthday, was on the way to take his son to the airport. There was a cab outside, and they were running late. Normally because he's fairly infirmed with a number of health issues, they had installed a lift for him to take him from the second floor to the first. And because they were running late getting to the airport, he didn't use the lift, and as he went down the stairs, he lost his balance and fell, and ended up with 3 cervical fractures, fractures in his face, a bleed in his brain. I mean, he was pretty sick and was brought, actually in the cab. The son didn't wait to call 911 because he was so severely impacted. He put him in a cab and they took him to Mass General, and he rested 3 times in the ER, ended up with tracheostomy, and was very ill for about a 10-month period as well. I'm sorry, about a 10-week period. And in retrospect, chronicled his experience in the healthcare system. What was fascinating to me as I read this, he talked about the expert care that he was provided at Mass General, and, particularly in the ER where he did He did cardiac arrest 3 times. They had difficulty placing doing the tracheotomy. They couldn't intubate him because of all the bleeding he had. But he talked about being up in the ICU in particular at Mass General, said the care was expert. He couldn't have asked for better clinical care. But what he noticed was the personal touch, the connection to the human beings around him, with the exception of his family and the nurses, was missing from his care. And he talked about even technology being so challenging, creating another layer of distancing from the patient, and how we deal with that is really an important consideration. But he talked about his experience as kind of a revelation in terms of how fragmented our system is, how rushed we are, how difficult it is to stay connected on that human level. And after he was largely through the acute part of his hospitalization, got copies of his record, and he describes reading his medical record. And he said, and what I read in page after page was these redundant recitals of my physiologic status, my blood pressure, my lab values. Not one note about how I looked, how I was feeling, or the conversations that I had with my physicians. Not one note. So I think this just is another example, I think, of the places where it really is important to reflect the patient in the care system. And I think particularly as we use technology like the electronic health record, the tendency is to want to just kind of check this off and check that off. And the patients can be missing in that process. So it's a really important, I think, an important thing that Dr. Relman shares with us as he thinks back about his experience. What I'm going to really spend most of the time on at this point, I'm going to try to leave, I'm definitely going to leave some time for questions, but I just want to talk to you about what was for me a very personal experience. And just trying to get the timer to go. The reason I was really invited to come here and speak was my own experience, and I worked in Boston. Dr. Morgan shared, I'm very much a Boston girl. I worked at the Brigham and Women's, Peter Bent first, and then the Brigham when it became Brigham and Women's, for 26 years in clinical practice. The last 22 of it were in the emergency department at the Brigham. And as a senior, pretty much a senior staff person in terms of my experience, because I was a very good ER nurse. I don't think there was much I couldn't manage in terms of the care that was necessary. We cared for, we were level 1 trauma center, so got pretty sick people in to our ER. I worked 12-hour shifts, and it was a Saturday actually, and had been a busy day. It was about midway through the afternoon, and that particular day I was assigned to do triage, and triage is when you assign an acuity to either walk-in patients based on their complaint or the ambulance patients, and you assign them to a particular part of the ER where they'll get the appropriate care. And so normally in that process, it's really about interviewing and assessing people, not so much providing the care directly. That would be a rarity. So on this particular day, a colleague came out. It was mid-afternoon, and it was busy, and she asked me if I could get someone to cover me and come into a room and draw some blood for her on a patient that she was having a lot of difficulty with. So I did. I got someone to cover me, and I went in the room and was able to get the lab work. And as I held the venipuncture site with one hand, my gloved hand, and the other gloved hand, I went up to put the needle that I just drawn the blood with into the needle box, which was actually above my eye level. I remember reaching up. And as I did that to put the needle in the box, my index finger was stuck by another needle that was protruding out of the box. And I knew right away it was a deep puncture because it bled to the outside of my glove. I have to tell you that my first kind of gut reaction to it, and it wasn't my first needle stick. I'd probably been stuck 4 or 5 times before that in the course of my 22 years down in the ER. And it was always something that we thought of as kind of part of doing the work, just kind of, it's something that's going to happen. And the first kind of reaction I had to getting stuck again was, I'm not going to sign in. I didn't want to come in on my days off for follow-up labs. I knew the protocol, and I just thought the likelihood, air-exposed needle, I was doing my own little assessment, very low for me to have a problem with this. But I was fortunate in that the nurse who had asked me to come in and draw labs on her patient was actually in the room with me at the time the injury occurred. And she looked at me and she kind of read my mind. She said, "I know you're going to sign in to be seen for that." And I'm grateful to her to this day because my care has been extensive. I'm getting ahead of myself a bit, but my care in the time since has cost over $1 million, and I certainly could not have afforded that if I had not reported that injury at the time. So I did. I signed in. I saw the nurse practitioner in the urgent area of the clinic. We had a protocol that asked for baseline labs, and then you come back in 6 months and get them redrawn. And the nurse practitioner actually recommended to me that I take the only prophylaxis we have for bloodborne pathogens. I had already had a hepatitis B exposure that gave me immunity, so I knew I wasn't at risk of hepatitis B. Hepatitis C was still in that gray area of non-A, non-B. Hepatitis C, they weren't sure what to call it at that point. It was a different kind of hepatitis. The thing people worried most about was the HIV. So the nurse practitioner said, it's a unknown source, high-risk area. You really should take the prophylaxis. And I deferred the prophylaxis because I was, I'm thinking, again, doing my own assessment. I also didn't want to come in on my days off. I worked hard on the 2 12-hour days I did, and I had no desire to be in there during the week when I didn't have to be. So I didn't take the prophylaxis. And about 5 weeks later, I started to actually have some physical symptoms that they were pretty vague. I really couldn't attribute them to anything. I started to have some nausea that would come and go. It would come time for me to take a lunch break. By the time I got down the cafeteria, I'd be so nauseated I didn't want to eat. I started having weight loss. I was having some abdominal pain on and off, just a lot of fatigue. Nothing I could really explain, but very vague symptoms. And I finally made an appointment with my primary, and I went in to see her, and this was probably about 3 months out of my injury. And I went in to see her, and she's someone I only saw on an annual basis because I was fairly healthy. I don't do anything to really abuse myself too much. I don't exercise as much as I should, and I probably could eat a lot better. I know I could. But other than that, I didn't really have any major health issues or risk factors. And so she saw me. At that point, I'd lost about 12 pounds, and she said, "Karen, I can see you're not feeling well. I can see that you've lost weight. I don't know what's going on." And I didn't tell her I'd been stuck with a needle because I didn't make any connection. Once I walked out of the ER that day and had my labs done and did what I need to in terms of the care after the injury, I just kind of put it away. So I went back to work. She couldn't figure it out. She did do some labs. Nothing showed up. And then probably about a month and a half later, I made another appointment to see her again because I was starting to have additional symptoms that I just didn't understand what was wrong with me. And on my way in to see her, and this is about 5 months out now, the injury, I was going by the occupational health clinic, and I'm walking down the hall, and I'm thinking, maybe I can kill 2 birds with 1 stone and go see the occupational health clinic and get my labs done because they needed them about 6 months out. Maybe they'll do them early. And then I'll go see my primary. And so I did. I stopped in the occupational health clinic. They did draw the labs a few weeks early, and I went on my way back. And I didn't tell them why I was in the hospital, that I was in there for the second time to see my primary physician. So I went to see my primary care physician. She, again, couldn't figure out what was going on. Walked out of there not knowing. And actually that next week, I was called into work because someone had a sudden family emergency. So they called me. I was available. I came in. And I was working in triage again. And about midway through the afternoon, I remember thinking to myself, I never heard about my lab work that I'd had drawn when I'd come in the week before. And I know they prefer to give it face-to-face. So I called up to the clinic, and it was about 3:30. And I said, I'm here. I'm doing an extra shift. I said, I can come up and get the lab results. And she said, can you come up now? And I said, actually, no, I'm too busy. Typical nurse, But I said, I'll be up in about 45 minutes if it slows down. So I did. I came up, and the clinic at that point had been closed, but the door was open. And I went in, and I heard there was someone behind a closed door in one of the offices. So I sat in the chair, and I remember looking at my watch and thinking, I have to get back down to work. I was working a couple more hours. And finally, a nurse practitioner opened the door, and I'd never met her before, and she called me in, and she sat me down, and she said, I need to have your labs redrawn. And I thought they lost them. So I I said, why? And she said, I remember her exact words were, they weren't negative. That's what she said to me. That's all she could get out. She's never said that to anyone. I don't know if she's ever had to say it to anyone since, but that was how she said it to me. And I remember thinking, in fact, I went back down to the ED afterwards. I remember thinking, I think she just told me I might be HIV positive from this. So the labs were redrawn in the clinic. I went back down to work. I didn't even think about hepatitis C. I didn't know enough about it. And it turns out today I think hepatitis C is the worst of the two, because HIV people can live chronically pretty well. We've got a pretty big arsenal of drugs now, and you can live with some side effects and be managed pretty easily in the HIV, whereas the hep C is kind of tough. Getting better drugs now that more people are responding to, but at the time, people were dying from co-infection. So at the time I had the labs redrawn, she said, come back next Wednesday at 10 o'clock in the clinic and we'll give you your results. So it turned out it was Christmas Eve, and I came in and came back, and the clinic was open and busy, and sat in the chair, and a nurse practitioner comes out, and she called my name, and she brought me into a room, and as I walked through the room, I saw the medical director and the nursing director and a social worker and an infectious disease fellow, and the nurse practitioner, and I looked and I'm thinking, I don't think they do this for everybody. So they proceeded to tell me that I was HIV and hepatitis C positive, that I'd seroconverted on both. And I was actually pretty acutely ill in terms of the lab work. My liver function were elevated, and I just had a lot of issues. And my viral counts and load were very high on both viruses. So I remember the first feeling of compassion with this, because I think they were all in shock. They didn't know what to do. And I remember looking at the medical director, and I knew him a little bit because I'd been at the Brigham a long time, and I looked at him and he was crying. Actually had tears running down his cheek. And I just remember I didn't know how to respond. I was in total shock. And I started, they basically, nurse practitioner said, what can I do for you? What can we do? And I said, you can get me a new doctor, because at the time it was an AIDS clinic at the Brigham, wasn't an HIV clinic. And I knew if I sat in the waiting room of an AIDS clinic, people would know that I had seroconverted. So I said, so I need a new physician outside the Brigham. I said, and I would ask you not to tell anyone that I seroconverted. I don't know how I'm going to deal with this. I've got a big family. I need some time. And I didn't, as well-intentioned as people would be, I knew that they would be calling me, friends, concerned friends, colleagues. And as I walked out by the elevator, I remember thinking to myself, I am never going back to work. It just hit me all of a sudden that I was never going back to clinical practice, and I loved my clinical practice. I was good at it. I was a great ER nurse, and I'd worked there a long time. And anyhow, it was Christmas time, and I went home, and I thought, my closest sibling is my sister, younger sister. And I called her on the phone, and I said, hey, Ruth. I said, they have too many staff on for Christmas, or this week. I said, so they offered me the week off. I said, how about if I fly out and spend Christmas out there? And she kind of got quiet on the other end of the phone, and she said, okay. And when I got there, I remember we went out in the car, and I said, let's go for a drive, and we got out in the car, and she pulled into a parking lot, and she turned to me and she said, okay, what's really going on? She says, I know they don't have too many nurses at the holidays. So I told her. She was the first person in my family that I told, and I spent the next week and a half or 2 weeks with my sister. It was comforting for me to be around her. She didn't know how to kind of support me. I didn't know how to support me. But one day, and this is the first kind of inkling of, really someone on the other side of this really understanding that this was pretty devastating. The phone rang one day at the house, and my sister answered it, and she said, Karen, it's for you. And I took the phone, and on the other end was a voice I'd never heard before, and he said, Karen, my name is Dr. Eric Rosenberg. I'm your new physician, primary care physician. He said, infectious disease attending over at the Mass General, and you're going to be fine. And I'll never forget that phone call. That's all I needed to hear. I didn't know if I was going to be fine. I really didn't. So for him to say that to me and to take the time to call me, to track me down, And to do that, that was the first moment when I knew, that was the caring part of it. That was the compassionate part of it, and it sticks with me. I came back to Boston, and I had my first appointment with Dr. Rosenberg, and we sat down, and he spent an hour with me, kind of going through what my labs indicated, and, this, with HIV in particular, there's slow progressors and there's rapid progressors, and, there are people in between, and he kind of spent time drawing graphs and describing to me why he thought I was this kind of progressor, and that I probably was going to be okay and be manageable. And then he turned to me and he moved off the paper he was drawing all the graphs on. And he said, he took another piece of paper and wrote something on it. He passed it over to me, and I looked at it, and it was a number. And I said, what is this? And he said, if at any night you wake up at 3 in the morning thinking about this, I don't want you to lie awake thinking about it. I said, I want you to pick up the phone and call me. It was this home phone. I mean, somehow God watched over me and got me to the right position, because I never had to use that because I knew I had it. And I'm not suggesting providers should all be giving out their home phones, but at that moment it was the right thing for him to do, to provide me some peace of mind around the care I was going to get, under him and at the Mass General. So he introduced me to a liver specialist. I started on both therapies, and at the time they really didn't know how to manage co-infection because people were dying from it. And I went on a pretty tough regimen of interferon and ribavirin and protease inhibitors, and I was taking about 18 pills a day plus the injection for the interferon daily. And my hair started falling out, and I'm fatigued, and just really, the treatment was making me pretty sick, and it was really the Hep C treatment. It wasn't, although the protease inhibitors, I have to say, I probably went through 5 or 6 different combinations of drugs because of side effects of the HIV. But whenever I would pick up a phone, he would listen to me, have me come in, examine me, and then change my regimen around. But he did that 5 or 6 times. And just hearing what I was saying to him and listening and responding in that way was huge for me. Finally got me on a pretty stable regimen. And so about 3 months out, I started to feel a little better. Things were stable in terms of my labs. And I started to read about needle stick injuries because, as I said, for nurses, I think, and for a lot of healthcare providers who use sharps, we often would think about it as just the cost of doing business. It was just, it's the environment you work in, And I started to read about it, and I realized, for the first time, I had no appreciation for how extensive the scope of the problem was across the country for healthcare workers. And based on the CDC and OSHA's estimates, anywhere, and it was a wide range, anywhere from 350,000 to 800,000 healthcare workers a year were getting stuck or exposed through sharps. Of those, a very small percentage are converted based on what they knew, and that's assuming everyone that gets stuck reports and gets testing done. So that's always a question too. Do you really know how many people are seropositive out of all the people? Because we know their underreporting rates are significant. But as I began to educate myself around the issue, I learned that we were in our 3rd generation of safety devices in this country, and only about 15% of hospitals offered their workers just one type of safety device. 3rd generation, they were working. Some of them were pretty good devices. And they just weren't being put into the hands of the providers. So what I didn't mention, I was president of the state association for the American Nurses Association in Massachusetts at the time of my injury. So, and I had a meeting coming up in Washington where the state presidents would go and meet with the president of the ANA and kind of share things that were going on in each state. And I knew at that point, I looked sick. The interferon makes you look kind of gray. My hair was falling out. I'd lost a lot of weight. Just the therapy, not illness from the viruses. And I called the president of the ANA and I said, I would like the opportunity to address the Constituent Assembly. That's the assembly of all the presidents and the executive staff. when I come to the meeting. And that was a bit unusual because they have a certain protocol they use when they have the meeting. And she said yes. I didn't tell her why. But I was also getting ready to testify on a bill that we had filed in Massachusetts. And at that point, no one in the ED knew that I had seroconverted. They only knew someone had seroconverted within the care provider ranks. And I knew as soon as I went to provide testimony for a bill we had filed in Massachusetts. That was the other thing. It's nice to be president of the state association, because one of the other things I did was have them file the first bill in Massachusetts to prevent the injuries as well. And they did, and this was the bill coming to the Joint Health Committee in the Massachusetts legislature, and they, I had a decision to make whether I would publicly testify about my injury and my illness. And so I made the decision to do that, but I knew I needed in the interim to get to people in my family, not have friends and others kind of hearing about it through the media. So I had enough lead time to do that, and then I also knew now it was starting to get out that I was sick, and I'm heading to Washington to this meeting, and I got up at the meeting, and I remember saying, based on what I had learned about the problem and how preventable it was, and that we weren't really doing anything to protect the workers, and I remember getting up and saying to the presidents, I'll go anywhere, speak to anyone to prevent this from happening to someone else. So invite me to your states. I'll work with your legislators. We'll get some kind of activity around this issue, because there's a lot of work to do. And over the next 8-9 months, I traveled to 26 states, many of whom filed a bill of one kind or another. And we also filed a new bill in Congress. There had been a bill that had kind of languished since the late 80s that no one really paid attention to. But this time, the ANA really took the lead and got a lot of stakeholders together, and they fashioned a bill that addressed amending really updating the bloodborne pathogen standard, which is a major protective kind of standard for healthcare workers, where it recognized for the first time that these devices were primary line of defense in these injuries. And up until that point, it had been a suggestion that people use them, that there were some devices out there. Maybe, use them, would be good. So I'll tell you one more quick story that I hate to tell because I get emotional still 14 years later, but two things. I had the opportunity, because I was out on this issue and traveling around talking about it, I had the opportunity to go to one of the chief staff people for the co-chair of the subcommittee on health, education, labor, and pension had a sister who was a nurse who got stuck by a needle. It's very convoluted, but that staff person approached her boss and said, we need a hearing on this. And she actually got him, and this is Representative Congressman Ballinger from South Carolina, a very conservative Republican leader in Congress, who wasn't crazy about the idea of regulation in any form or fashion, but he, along with the other co-chair, decided that yes, they would have a hearing. So ANA asked me if I would provide the testimony on their behalf. We had the Secretary of OSHA, Occupational Safety and Health Administration there, Charles Jeffress. We had the epidemiologist there, and one other person provide testimony. And at the beginning of the hearing, Congressman Ballinger said, I have to tell you, this isn't, to think about more government regulation when I have hospitals in my state who are financially teetering on the edge, to think about imposing more regulations that involve more cost. I'm not crazy about this idea. He basically said that. At the end of the hearing, he said, you have a new champion for this bill. It was the most fabulous kind of tipping point. 3 weeks later, maybe, I watched on C-SPAN as Congressman Ballinger got up to a mic in the House. And he stood at the mic and he said, I want to move by unanimous consent. That means they don't take one vote. By unanimous consent, this bill. And they did. The whole House. 2 weeks later, I was at Mass General for one of my appointments with my primary, and I was leaving, and I had my beeper on for the State Association. And it went off, and this is the part I have a hard time telling. And it went off, and I called the office. It was my office, and the executive assistant said, Senator Kennedy called, and asked you to call him at this number. So I did. I hung up. It was a payphone. That's how long ago this was. And I called, and the person on the other end said, Senate floor. And I thought, oh, God, I transposed some numbers. And so instead of hanging up, I said, I'm not sure this is the right number. I thought this was the number Senator Kennedy had asked me to call him. And he says, oh, hang on a minute. He's right here. So Ted Kennedy gets on the phone, and he said, Karen, I want you to be the first to know. He said, your bill just passed the Senate by unanimous consent, and it's on its way to President Clinton. And it was just for him to take that moment and to do that. And I think of caregivers, it's not just the people providing care within hospitals and communities, it's everyone around you that provides you the support you need. And that bill did go to President Clinton's desk, but we had a formal signing, and that's what you see here. I actually had the opportunity to go to the Oval Office and be there with Secretary Shalala and about 15 other people who were there for the official signing of the legislation that for the first time really reformed, I think, provided an opportunity for us to prevent these injuries and utilize technologies that were now available that really put some pressure on employers to provide those to the direct care workers. So, for me, the journey was it seemed like it went by in a moment. But, as I think about the days and the conversations and the work that was done to move this kind of legislation, and legislation, I've learned in my role as ANA president, legislation doesn't fix things. It's just kind of the beginning opportunity. Because you have to stay with it, and you have to make sure there's enforcement, and you have to make sure there's compliance, and you have to raise awareness, and all those things are still ongoing 14 years later in terms of this legislation. But for me, it was about coming out of a personal experience and knowing I had some opportunity maybe to prevent one other person from getting stuck. I was saying before we began that I go to Mass General still for my labs periodically, and I look at the safety device that's being used to draw my labs, and I think that wasn't there 14 years ago. So we're seeing a culture shift, but for me, this was about people that provided me enough caring and compassion and support to allow me to do other work to move this issue as well. Because trust me when I tell you, I look back on that year when I was taking interferon and protease inhibitors and sick as a dog some days, and I wonder how you get through it. But you do, because it's a bigger purpose. I think the last thing I'll just say in terms of this psychosocial connection to care, I watched the Kenneth Schwartz Center has an annual event where they recognize compassionate caregivers, really excellent caregivers who extend compassion as part of their practice. And I was actually on the first award committee, and I remember the applications that came in, the nominations that came in, and the fabulous care that's going on in spite of the challenges within the system. And recently, one of the speakers, they always have a kind of a keynote at these events. The keynote was Harvey Feinberg, who is the immediate past president of the Institute of Medicine. He's a physician. And he actually talked about compassionate care. You can actually pull that up on YouTube, his speech about this. But what he talked about was the necessity for compassion and humanity in the care process in healthcare. That you can't have health care without it, that it really is a necessary part. But the other piece of it is it needs to be one of the mindful, intentional aspects of the way we design our system. Because right now, the challenges that are thrown, that create barriers to providing really good, compassionate care that looks at the whole person and what their needs are and what their preferences are in terms of their own health and how it's managed. The system works against us so much. And Dr. Feinberg said, there are particular barriers that we need as providers to look at as we redesign healthcare. And I think that's the opportunity now. We're in the middle of a transformation of a healthcare system, more with respect to access, but there's also opportunities to transform it in terms of how we deliver the care. And that work is beginning. Part of that is how we design the environments in which the care is given. And what Dr. Feinberg talked about in terms of the factors that enable caregivers to act in a compassionate manner to address the psychosocial issues are things like time, time to experience and demonstrate human connection with that person you're caring for. It's a luxury sometimes in our healthcare system. He also talked about the physical environments that we need to make sure as we design this healthcare delivery system, and it's not just about the teams, it's really about the physical environment as well, is that we think about things like the ability to provide a quiet environment where there's privacy and maintain dignity for people, allow families to be, with their loved ones when we provide the care. I think that certainly the attention to the distancing that Dr. Relman talked about, the distancing potential of technology, how can we overcome that? Because he talked in his, if you read it, he talks about the daily rounds that would occur outside his room when he was in the ICU, and he talked about the physicians would always stay outside the door, and they'd be out there looking, because they could still see into his monitor, and they could see what his O2 sat was, and then they'd be out there talking about labs and all that stuff. But he said, it challenges you and creates greater distance, so that human connection is lost. And physicians, it's part of the problem is how we educate our healthcare providers, whatever the discipline is. But that the technology, while it's a tool, also creates additional barriers. We need to figure out how we can overcome that distancing that it provides. I think that the last thing, and the last thing I'll say in terms of Dr. Feinberg's comments, most of all, he stressed that the greatest inhibitor for individual caregivers showing compassion is that they themselves are disrespected, under chronic stress, and not permitted to express compassion. So that's a whole nother issue that we need to address within healthcare. The final thing I'll say as I wind up is just to say, for me, and I've had the great privilege of serving as ANA president for the past four years, but I think it's become even more acutely, I've become even more acutely mindful of the need for caregivers to care for themselves. Not just about others caring for you, but to care for yourself. And that the fact is, it's hard for us to care for others if we're not able to care for ourselves and get our basic needs met. I think certainly in nursing we have a history and tendency to put everyone else before ourselves, and we've learned over time that is the absolute opposite of what we should be doing. That if you're not well rested and you're not you're not eating right, and you're not in an environment where there is respect in the time, all those things, and you're not addressing those needs, that you are so not able to be present for your patients in a way that they deserve to be cared for. So it wasn't just when I received this invitation from the dean, it wasn't just that this was about Boston University inviting me, because that was an important part for me as an alum. But it was about the fact that they asked me to talk about the psychosocial aspects of care, that for all of us has to be front and center in terms of how we provide the care, that if we are addressing those needs around compassion and caring and human connection, then people are getting good care, and they know it. So I thank you for the opportunity to be here. It's wonderful to be back at BU, and thank you all for coming. So we have some time if there are any questions. Just going to stand out here a little bit, get up from behind that podium. That was really for the lights and for the camera. So, any questions on anything? And I'm sure comments. You all are out in the care arenas and have firsthand experience yourselves. So.
Can you hear me?
Yes.
Yes, okay. I'd be interested in your observations as current president of the ANA of what other actions are people trying to move forward that have the potential to increase the possibilities for compassionate care as you see it.
So I think the attention to the environment's an important piece, and it's more and more the research is kind of building on itself that says it's not just the caregiver and the will they have and the knowledge and experience they bring to it, but it's also the environment in which the care occurs. So we think about things like communication and collaboration and the respect that we offer one another as we work side by side, and more so as care delivery is transformed into a team kind of delivery model. The environment becomes really important, and it's an environment that needs to be built not only from the ground up, from the top down too. It really does rest with the culture and with the leadership within the institutions, and so that providers can do what they do best on behalf of patients. I hope that's part of what you're talking about. But I think the other thing, I'll just share one of the initiatives out of ANA, and it's something one of the privileges of being the president of ANA is you get to have a couple of pet projects here and there. And one of mine is a campaign that we launched last year called Healthy Nurse. I sit on the advisory committee for the Harvard women's study. And it's clear that nurses overall, if we compare them to the general population, are at least as needful in terms of their physical health as the general population is, and we're a better educated part of the healthcare system. So it really is about creating a mindfulness among the providers and helping them value themselves as much as they value their relationships with the patients. So it's been we have a risk appraisal tool that we're getting nurses to kind of enter data in. We've had some success stories already around mindfulness and people losing weight and stopping smoking, and it really is feeling like you deserve it too. So that for me has been a fun thing to watch kind of evolve my time at ANA.
I was wondering if you see any different approaches for compassionate care at the end of life versus the ER or just in the regular hospital.
I think there's a couple of things that come to mind when you ask that question. One is the scale out of the rounds around compassionate care that we're seeing that, in part come out of the work of the Schwartz Center, where teams are now building this into the conversations as they round on patients. And that we're taking advantage of opportunities to have those conversations around ethical care. I think where they didn't exist before. I think there's a level of sensitivity that's growing, not just from a financial standpoint. It's not just about using resources, because it's very expensive what we do to people at the end of life. But it's really about quality of life and making sure that we get that patient-centered. What's the patient's preference? What is quality of life? What has meaning to them in their life? So that's one opportunity, and now I'm going to show you. I'm getting older. I'm forgetting the second one. I don't remember the second one. Sorry.
Are you guys involved with the MOLS program, the state program for informing doctors to, it's MOLST?
I'm not familiar with that one. I know the other thing I was thinking about is the hospice movement, kind of moving into you see it transitioning into a palliative care kind of model, where it's not just about end of life, and I know that's what you spoke to, but it really is about comfort care and making sure that we address what the needs of people are in their own homes and really respect what it is that they value and provide that level of comfort where it doesn't always have to be high-tech cure care. It really should be about what provides them the ability to live out their lives, whether it's with chronic disease or whether it's with end-of-life kind of issues, in the most dignified, thoughtful, caring manner possible.
Hi, Karen.
Hi, Angela. Angela's a colleague of mine at the Department of Public Health.
So I just wondered, you mentioned that it's really important for nurses to take care of themselves. And as somebody who works in occupational health and safety, I think it's important for employers to take care of the nurses who work in those institutions. So I wondered what what could schools who educate healthcare practitioners of all types do to help prepare practitioners before they enter the workforce to let them know that their health and safety is important, and what measures can they do to help protect their students?
Yeah, education's an interesting challenge. The education system and how we kind of, just like we do in clinical practice, we pilot higher and deeper. Now you need to add this to your curriculum and add that to your curriculum. But I think it's a philosophy, because the faculty also have a need to care for themselves. They're older, and they're in difficult environments too. So it's a culture shift. It's really about not only what we can teach people coming into our respective professions, but also how we treat one another. I think it begins with that.
I was struck by your comment that you reached up to put the needle in the needle box. And you also mentioned there's a third generation now of protection devices. So has the reaching up been fixed?
So there are standards, but it requires enforcement. But there really are standards for eye level. They actually have measurement, and there are experts in this room beyond me. But I wasn't able to actually see into what was an overfilled box. I think there's more attention to it in some places. It certainly isn't where it needs to be. But there is a standard now. Whether or not people are complying with that, that's a whole other issue around passing laws and enforcing them and making sure that the workers themselves know what their rights are and what is the right way to care for themselves. So demanding that when they see that there is a kind of a deviation from what is expected as standard practice. So that's also part of the campaign to raise workers' awareness. 14 years later, we're still having those conversations. But we do know what is likely to work best. It's just a matter of getting it kind of universally applied. So.
Do you have any idea how many needle sticks occur for healthcare workers today in an annual basis?
So one of the difficulties with the financial pressures in the government is that there's less monies for agencies like OSHA, or I should say NIOSH or CDC to collect that data. So there really is no surveillance right now going on. There's some proprietary surveillance that was going on out of University of Virginia. We're fortunate to live in Massachusetts, where we actually passed our law within that year as well, where we have the most stringent standards for reporting. And I'd say 100% compliance based on the work of the Department of Public Health around reporting injuries. So there's an ability to track and to see where progress is and isn't being made. But it is problematic that there's no surveillance going on in this country. In fact, if you go on the CDC or OSHA's site, you'll still see the same statistics that I saw in 1999 after my injury. There are some who might say we're even way beyond that was an incredible underestimate of the problem at that time, and that if we were to really get every reported injury, that it would be far beyond that. We have made progress. I don't want people to feel like we haven't. We've made progress. But we're seeing areas where there's really entrenched cultures, where it's really difficult to change behaviors and incentivize certain providers to change the way they do things. And ORs are notoriously one of those places, because the culture is a bit of often fiefdom, where the surgeon has complete control over the instruments he uses and the practices he uses, whether they're safe or not. And really it shouldn't be that way, because it affects everyone in the environment. So surveillance is an issue, and it's a conversation we've been having recently about how we're going to get that kind of jump started.
If there's no further questions, or is there one?
Hi, my friend and I are in the Connell School of Nursing from BC, and we're freshmen, and we're just wondering, like, what are some advice that you can give to undergrad, like, nursing students? And it's kind of...
Any advice I can give you? Stay at the Canal School. I love BU, but they don't have a school of nursing anymore. I think I would advise you to learn what your rights are under the law and be your best advocate. Don't accept what's happening in the larger environment. And when you're done with your education, you go out into the workplace, make that part of your interview process. It's not just about someone interviewing you for a job, but it's you making sure that you're going to work in an environment where they're very mindful around workplace safety and health. So, thank you.
Did we have a last question?
Oh, that's okay.
First of all, thanks for coming in, Ms. Daley. Appreciate it. I was curious if you knew, in terms of, I guess, the practicing of social health and implementing that in the healthcare system, were you able to find differences among the American healthcare system versus other, either European or Eastern healthcare systems?
So
Are we doing like the same as
how well they do in the different countries
how
in terms of
America
psychosocial
ranks
kind of
care?
aspects?
Yeah, or if you know,
I don't know. Often what you hear is anecdotal kind of information when people travel to different countries versus the U.S., maybe Canada, and here. But that's individual experience. That I don't know that there probably is literature out there. I don't know. There's been research in this arena. But, I think if you can, there are proxies for it, and I think Dr. Feinberg said very well, it's the time to be with the patient. Although time isn't time like I need an hour to get to know a patient, it's really being able to stand there and be present and relate.
Yeah, because I wonder too if the healthcare system itself, I don't know, in terms of like socialism, or I know with about the American the Affordable Care Act and how that implementation will change the, I guess, implementing psychosocial aspect of healthcare.
So the Affordable Care Act is really about access to insurance. I mean, if you really look at what the original purpose, and what they're trying to do on top of that is to build some value, performance kind of incentives into it, so the quality of care is driven by those incentives. But the psychosocial aspects of care drive quality. They drive outcomes. So as you look at outcomes, but in terms of looking at that specifically and comparing it country to country, I don't have that information.
That'd be interesting too. Okay, thank you.
Thank you.
Just have a last question.
Sure.
Last question.
Thank you. I'm a doctoral student in School of Education. I'm writing a dissertation on the healthcare life services, the health services programs in vocational technical high schools. So I know that the compassion is not the kind of skills that you can develop like English skills and mathematics skills, but I was just wondering your opinions about how to develop that skill among high school students.
So I might argue that there's some literature that talks about the emotional intelligence as being really one of a very important aspect or competency, I should say, is if you're in the healthcare system, that kind of intuitive, kind of connecting kind of sense. And based on the literature I've seen, not everyone brings it into their programs, but it's something that can be learned. They've done some research on that. So it's an interesting thought to think about that as being part of the competencies that you would want to develop in anyone going into healthcare, regardless of what the role or area of practice is, that is an important component. And I think it's just another one of those things that is so time pressured in terms of all the knowledge-based competency kind of curriculum going on, that that we need to come back to this compassion kind of based competency and really spend some time making sure that that's what people bring to care as they go into practice. So thank you for that question.
So, thank you.
We already did that.
And I sense there's more questions, so I welcome everyone to go up one floor to the Setterberg Lounge where we have a reception right now. So, and thank you again
Thank
for a
you. Thank you
fascinating
for
talk.
inviting me.